right? The patient is going to be short of breath. They may or may not present with chest pain. If it's chest pain, it's going to be non-cardiac chest pain. It's going to hurt worse when they breathe in, right? If we recall, chest pain that's of a cardiac nature does not change, right? They take a deep breath, you can push on it, you can move around. It's that same pressure or crushing feeling. Pleuritic chest pain is going to change with inspiration, expiration, or movement, okay? What's another, and obviously that's gonna be a medical, if we have a pneumo, okay? What is another respiratory emergency? CHF, who said that? All right, so these guys are kicking your butt. Take notice. All right, so what does CHF stand for?
Heart failure.
Okay, what kind of heart failure? What's the C stand for? Congestive.
No, congestive. Oh my
Congestive
God.
heart failure. Okay, so as it pertains to a respiratory emergency, what do we see in a CHF patient? Fluid buildup where? In the lungs. Okay, we can be a little more general there. Do we see fluid anywhere else with CHF patients?
Depending on the side of the failure, there's potential extremity edema.
Pedal edema, excellent. And you already nailed that it depends on which side of the heart's in failure. So let me explain that to you. You can come this way so you're not hiding because I'm watching. Okay, so if we recall our circulatory system, blood from the body comes into the right side of the heart via the inferior vena cava or the descending vena cava, right? That's our big vein, and it goes into the right side of the heart. From there it goes to the lungs where we do our gas exchange, and then it goes to the left side of the heart. From the left side of the heart it goes out to the rest of the body with oxygenated blood. Everybody agree? Okay. So if the right side of the heart is failing, meaning it can't keep up with demand, the fluid starts to back up, and it backs up into the body. So where is gravity going to take that? To our feet. That's why we see people with ankles, with those really big swollen ankles. Okay, if the left side of the heart is backing up and can't keep up, that fluid's going to back up into the lungs. So left-sided heart failure is pulmonary edema. Right-sided heart failure is pedal edema. Okay, typically these patients are going to have both, but they can have one or the other. And obviously for a respiratory emergency class, we're talking about the pulmonary edema. So what position do we want to have our patients who have pulmonary edema?
Upright.
Upright. Why is that?
Because you put them back, I think it could kill them.
They're drowning, right? So it just so happens I created a high-tech prop here.
No way.
Look at that. So imagine this is a lung and it's got some fluid in the base. Now all this surface area that's clear is available to exchange gas, okay? Same amount of fluid, look at what we've done to that same surface area. We've cut it significantly. So what's going to happen, and because CHF is a chronic condition, okay, it happens over time. And it's usually pretty well treated through medication, usually diuretics, right? But what will happen is Grandma will be sleeping and she'll notice that she's a little short of breath, so she props herself up on a pillow. And then a couple of weeks later, she adds another pillow because that fluid just keeps building up, right? And so over a course of weeks to months, the patient can go, and they can be pretty stable, but they just find themselves going from, well, a month ago I was sleeping in bed, and now I'm in the lounge chair in front of the TV because I can't lay down. Okay, so that's very typical kind of progression. Oh damn, I had an answer for Mark that I didn't share with him, so I'll need to get back to him on that. It has to do with this. Why would people not call us? Wait that long. Okay, so yes, we want them in a seated position. If they are lying flat, we're going to sit them up. We're not going to let them work. We'd also like to get their feet over the end of the bed and have gravity work for us as much as possible to get as much of that fluid out of their lungs as possible, okay? What is another respiratory emergency?
COPD.
What's that?
COPD.
COPD, what does that stand for? Chronic,
Obstructive.
obstructive,
Pulmonary.
pulmonary
Sort of.
disease. Okay, so what's happening in the lungs with COPD?
You have a bad, respiration, respiration of your
Alveoli.
alveoli. Yeah.
Okay. So the alveoli is bad. Can you elaborate?
Yeah, kinda, instead of having its own individual, like, I don't know, the way they describe it was like grape-like, structure, kinda like turns to mush.
Okay, kind of, pretty close. So there are two things that happen with COPD. One is a loss of surfactant, which is a coating on the inside of the lungs. Okay, the other is a loss of elasticity in the lungs. Okay, so we all remember that experiment that we saw when we were kids on Sesame Street or whatever, where we had the bottle and it's got the two balloons on the inside that represent human lungs, and it's got a straw that comes out the top that represents our airway, and it's got a balloon across the bottom which represents the diaphragm, right? The lungs are not inflated at this time, it's neutral pressure. When we pull down that diaphragm or that balloon down here, it creates negative pressure in the pleural cavity, which then inflates the lungs, right? When we release that, that returns to negative or just neutral pressure, and those lungs contract. Are we all on the same page? We agree, okay? So with a COPD patient, let's say we take those balloons out and we stretch the shit out of them. Okay, all of a sudden that little balloon that was that big is now a floppy thing like that. And we put it in here and we pull that same diaphragm, those lungs no longer inflate all the way. And when we let it go, they don't retract all the way because they're so stretched out. That's what COPD is. It's that loss of elasticity. So a COPD patient will actively have to work on their expiration. So they do what's called a pursed lip breathing. And if you watch people breathe, you'll look, and when you see it, you're like, COPD. They'll be like this. And they're literally they're using all of their musculature and accessory muscles to push that air out. So that's COPD. They're gonna present with wheezes. CHF are gonna present with fluid, right? So we're gonna hear expiratory wheezes with the COPD patient. Good. What's another one? From the dudes in the back who are answered nothing yet. Another respiratory emergency.
Pneumonia.
Pneumonia, excellent. So how is that gonna present? What are the lung sounds gonna sound like? Why don't I tell you?
I don't recall.
Okay, maybe you haven't learned yet, so that's what we're doing today. So pneumonia is an infection in the lung. It's going to present from a lung sound point of view, it's a very subtle change. All right, so when you hear fluid in the lungs, you'll know it, right? When you hear somebody who's really junky and got a lot of mucus and stuff, you'll know it, right? Pneumonia is very subtle. So they're going to be primarily clear breath sounds, except in one area, and it can be anywhere. It can be on the top, it can be in the mid, it can be on the bottom. It'll sound a little different. And I like to describe it as a little bit muffled. And so what that is we call that consolidation. And what is happening in the lungs is that infection starts out and it starts to grow. And as that infection grows, that patient becomes febrile, so they start to present with a fever. And when it grows enough that it is starting to interfere significantly with the gas exchange, that's when people call us, because now they're short of breath. It's not an ALS call. And it's one that we don't even necessarily need to transport. If they can get in with their general practitioner that day or urgent care, all they really need are antibiotics. Okay? So, unproductive cough. So with bronchitis, for example, we're gonna see a lot of that green, nasty, yellow mucus. Not gonna see a whole lot of mucus with pneumonia. Okay, so bronchitis is coming from the sinuses, and then all of that mucus starts to get infected. So you can have pneumonia without any kind of real instigator or catalyst. If somebody gets water in their lungs from swimming or whatever, that's called aspiration pneumonia, or if they vomit and they end up, right? That will create infection inside, but they don't need that. They can just have bacteria in their lungs that start to develop. Good, Casey, nice job. One more, Derek. Micah. Come on, baby.
Asthma.
Asthma, good. Funny you should say that's on skill sheet number 71.
Oh.
So what are we gonna hear with asthma? What kind of lung sounds?
Wheezing.
Wheezing. Inspiratory or expiratory? You had a 50-50 shot, that wasn't right. So it's usually gonna be on expiration, right? They're usually expiratory wheezes. They can be both, but again, what's happening inside the lungs with asthma?
The airway is constricted.
Right, bronchial constriction, right? So imagine your garden hose is one of your bronchioles and you step on that thing and you reduce the amount of flow. You're still getting flow. Now because of that pressure differential that we talked about, right? It's easier for them to get air in. That's the active process of breathing. It's harder for them to get that air out. So just like the COPD patient, they are working to exhale as opposed to inhale. Inhale is easy for them. Exhale is what's hard because it's all clinched up. So the MDI, the metered dose inhaler, that is a bronchodilator, okay? It also has the side effect of tachycardia. So you will, if you have a patient who has taken an MDI, their heart rate's gonna be between 110 and 120. Okay, that's a normal side effect of the medication. Okay, good. I think it's you, Derek. What do you got? Respiratory emergency.
Bronchitis.
Okay, bronchitis, we're gonna see you're gonna have really junky lungs, a lot of mucus, a lot of fluid. Can be life-threatening, particularly in kids. Kids, adults die of cardiac arrest, kids die of respiratory arrest. They're weakest in their lungs. So if you see a kid who has accessory muscle use in their breathing, and what am I talking about with accessory muscle use? Intercostal breathing, belly breathing, clavicular retractions, so this is all sucking in. That is a sick kid. And they need a medic right away because those kids can crash. The thing about kids is they can compensate and look great until they don't. Adults will decompensate slowly, kids will drop off the cliff. They'll be fine and then they're dead. And it's not cool. Okay, everybody answered at least one question. Any more?
Pulmonary embolism.
A PE, right. So we're gonna hear very little on a PE in terms of our stethoscope because we're looking at a pretty minor area. They can present with pleuritic pain, but not necessarily always. Though one big PE patient I had was mowing his lawn, and he just felt something wrong, and he literally stopped where he was, called 911, and literally was afraid to move because he didn't know what was wrong, but he knew something bad was wrong, and we literally picked him up and put him in our rig without him moving. He was flipping out. Definitely going to be a medic call. You're going to probably see some hypertension there, some shortness of breath, but you're not going to hear a whole lot in terms of lung sounds, okay? Because it's a blood clot that is now preventing the gas exchange, so you're not going to hear that. Anything else? What?
Anaphylaxis.
Excellent, anaphylaxis. So what are we going to hear with the anaphylaxis patient? What kind of wheezing? Stridor, where is Stridor?
Lower airway.
Upper airway. Yeah, so when I have an anaphylaxis patient, the first thing I do is I put my stethoscope on their throat, because that's gonna kill them. What's the other way anaphylaxis kills people? What? What? Leaking?
I know, I was just thinking of sepsis, never mind.
You're totally dead on.
Oh,
Yeah.
yeah, they're like, your vessels, like.
Yeah, porous vessels. So, but what it is, so let's back up a couple of steps. Anaphylaxis will kill you two ways: upper airway obstruction and a hypotensive emergency secondary to vasodilation, which includes porous vessels, right? So it can create, so again, we've got our three pieces of our circulatory system. We've got our pump, our pipes, and our fluid, right? So imagine all of our vessels are our pipes, right? And they're typically not all the way open, right? They constrict and expand depending on what the body needs. So what happens if we throw a switch and they all just open wide? That fluid that was an appropriate amount before is no longer appropriate, okay? Just because we change the size of the pipes. Now with sepsis as well as with anaphylaxis, those vessels become leaky. As Jenna very, very intelligently pointed out to us, they become porous and all of that plasma starts leaking into the body. So then you've got even less fluid in those pipes. So the definitive treatment for anaphylaxis is epinephrine, vascular constriction, bronchodilation, and increased heart rate. So it's the perfect drug for it. Anything else on the respiratory emergency side of things? No, I think we hit them all. I think we hit most of them.
So an MDI is a bronchodilator and it increases the blood pressure or the heart rate.
Yes,
Whereas like nitro is a vasodilator,
Right.
so it decreases.
yep,
Okay.
exactly. Nailed it. Okay, so what I'm gonna do is I'm gonna demonstrate the MDI